Good afternoon, everyone. Welcome to Providence General Foundation's Innovations at Prov, the speaker series connecting you with our Providence experts on topics you've said you want to learn more about. I'm Dr. Jay Cook, and I'm happy to be your moderator tonight. I practiced vascular surgery at Prov Everett for about 27 years, and for the past 4 years, I've served here as the Chief Medical Officer. This is the first program in our series, and today's topic is innovations in stroke care. Many of you have invested in the work we'll be talking about today, and we're delighted to share the very exciting and very recent advances made possible because of your community support. First, I want to cover a couple of quick housekeeping items. First, attendees aren't visible to other attendees, and everyone but the speaker will be muted, so we don't have any unwanted audio interference, echoes, or distractions from your pet or anyone else's pet during this presentation. But we do want your questions. So those who joined with a computer, a tablet, or a smartphone can submit typed questions during the sessions using the Q&A feature. All questions and the name of those who are asking the questions will not be seen by the other attendees. However, on our screens, we can see the questions, and we'll do our best to get through them all. And yes, there's a disclaimer. Although we are all doctors on this panel, this presentation is not a replacement for seeing your own doctor with your specific medical questions. This webinar content is not intended to be a substitute for seeing a professional for advice, diagnosis, or treatment. Always seek the opinion of your medical professional regarding any question you might have about stroke or any other medical condition. We're here tonight so that you can get to know your local doctors at your local hospital and hear straight from them what's happening in their field right here close to home. So let's meet tonight's panel. When everybody gets on, you can see them, but I'll go ahead and introduce them. Dr. Tarvinder Singh is a neurologist and the medical director of our award-winning stroke program here at Prov Everett. There he is. As you'll hear in the next hour, Dr. Singh's vision and work has really impacted this community and has elevated the stroke care we're able to provide at Prov Everett. Dr. Jens Loh is an interventional neuroradiologist and neurointensivist. There he is. That's a big mouthful, and in a few minutes he'll explain what all that means and why his specialty is such a big deal here at Prov Everett. Thank you both for being with us. We'll start with Dr. Singh. Start from the beginning, please. Tell us the basics about stroke.
Thank you so much, Dr. Cook. I'm going to share my screen so people can see. Let me know when you can see it. Are you able to see this? Okay, yes. Awesome. All right. So it's my honor to be here and talk about this topic, which is very close to my heart. I am Director of Neurology and Stroke Program at Providence Hospital, and also clinical co-lead at Clinical Program Services for entire Providence. And I want to share a little bit about, sort of what my story is and why I am doing what I'm doing. I grew up in a small town in India and was very fortunate to be able to join a technology institution, something kind of like MIT here, and really had a good time doing it, and then joined AT&T Bell Labs and Oracle and Microsoft and worked in that industry for about 10 years. But something in me was always missing this feeling of connection and service. And while I felt like you could do a lot with technology in terms of being on computers of billions of people, I just felt like I wanted to be closer to people directly. So I changed my career and I went to University of Washington, did my pre-medicine, medical school, residency, and then fellowship, and then joined Providence in 2016 as a stroke director, as well as a neurohospitalist, taking care of patients with acute neurological condition. And I feel like the more I have worked in this field, the more I've felt sort of in balance between these two parts of me, one that is always looking for intellectual curiosity and stimulation, and the other part which is looking for um, fulfilling our heart and caring for people. And I am really fortunate to be part of this community itself, which is what has helped build the neuroscience program and the stroke program in our hospital. So thank you so much. And with that, I'll start an introduction about stroke. I think most people I have talked to have heard about stroke. And the reason is it's because it's really, really unfortunately very common. About every 40 seconds, someone in US has a stroke. And about every 4 minutes, someone in US dies from a stroke. And many of these strokes are preventable. So there's an opportunity for us in the stroke world and in the medicine community um, to care for these people and also to help prevent the stroke. And I think education is that big component for me, and I that's why I feel really excited to be here and talk about this. When we talk about stroke, we categorize them into two main categories. One is, you see on the left, which is the ischemic strokes, and the other ones are hemorrhagic strokes. By far, the most common strokes are the ischemic strokes, composing about 85% of all strokes in the world. And these strokes are caused when there is a blockage of a blood vessel, either from a clot or from a plaque. And the symptoms we get from a stroke and the disability we get from a stroke depends on how big of a vessel is blocked and where is that vessel located. So if a very large vessel, such as this one right here, gets blocked, you could have complete hemiparesis of the other side and really, really bad symptoms. And depending upon the location, if you had a really small stroke in a very small vessel, sometimes we may not even know that we had a stroke. So again, there's a huge diversity in terms of how people present with a stroke after an ischemic stroke. Hemorrhagic strokes are, compose about 15% of all strokes. They happen when there is bleeding in the brain, either inside the brain or on the surface of the brain. These strokes are pretty deadly. They cause a lot more disability. And the treatment for them is very different than the treatment for ischemic stroke. I'll touch briefly on differences in care, but most of the talk will be focused on the ischemic strokes. So I'll start with a case. And I want to, this is a fictional case, but it's not that uncommon for us to see this in our community. So we have a patient who got up this morning at 7 a.m. and around 7:30 a.m., her husband and her had a cup of coffee together. Around 8, she went for her usual 30-minute walk with her dog. And then when she didn't come in time, her husband got curious. He went out, and at around 9 a.m., she found that patient was unable to speak and had right facial weakness. She was able to understand, and so she was able to walk. So her husband brought her back into the house. And then the question is, how does he know that the patient is having a stroke? And one of the mnemonics that we talk about a lot is this thing called BFAST, which is easy to remember for people. And B stands for balance, which is, if we have sudden loss of balance or sudden loss of vision, that's E, sudden loss of facial weakness, that is F, sudden loss of arm or leg weakness, or sudden loss of speech, then we suspect that stroke is very likely. And then T stands for time, which is it's time to call for help right away. And this is really, really important to remember, because if you're having a stroke and you're able to get care quickly, then there are treatments that we have to help people. So in the case that we just talked about, I often get asked about what the next step for her husband is. And these are all valid questions that have been asked from me in the past. First thing that people say is, should we give aspirin to this patient while we're getting help while other people are coming in. And the answer for stroke is no, we should not give aspirin because remember there were 15% of strokes that were bleeding strokes. And if we gave aspirin to a patient who's already bleeding, then that could cause bleeding to get worse. So aspirin is not something we give to stroke patients. Very different from a heart attack where aspirin is often indicated. Um, you know, some people say, how about we just hydrate the person or just, talk to them and see if they get better on their own? How about calling primary care provider and asking for help or nurse line? Or however, driving her yourself to the emergency department. And often many of these things are thought of because they don't want to trouble the wonderful community EMS, if they don't have to. They want to sort of take care of the patient themselves. But I want to emphasize, and this previous chart mentions this, that there is no time to lose. And in this case, the best solution and the best thing we can do is for us to call 911 so the patient can be brought into the emergency department really, really quickly. And the proper treatment can be done starting at the scene. There are some critical pieces of information that the EMS will ask you, and when you come to the ED, they will ask you. And it's really, really important to remember and mention these things. And if you remember in the case, I was talking about time, what time did she wake up? What time did she go for, have breakfast together? What time did she leave the house? And those things become really important because for our treatment, we go by something called last known normal. So if someone's last known normal is 5 minutes ago versus 5 hours ago, things changed a lot. In 1980, there's a author who wrote about our hospital and its history, and there was this very heart-touching paragraph here where a patient had a mother who had a severe stroke upstairs. She was laying consciousness, and all the sister could do was comfort this gentleman. There was not much treatment. Things changed in 95. And that changed because of this medication called TP or alteplase. It's a medication that is a very strong blood thinner that is given to patients who are having this ischemic, the clot kind of stroke, to break up the clot and make the blood flow again in that territory so they don't have a large stroke. The key part about this medication is it can only be given to patients who present within 4.5 hours of their last known normal. And the sooner we give this medication, the better it is. So there's a graph on the left here. And there, it's a complex thing to understand, but the main thing to understand here is this axis on the in the bottom is the time from when the stroke started. And this is the odds of getting better. So if we gave this medication within 90 minutes of last known normal, then the odds of that person getting better is 2.5 compared to if they didn't get the medication. And this is a number that we use, and Dr. Lowe will use probably also in his talk, which is how many patients do we have to treat to make one better? And this is a number needed to treat of 4 to 5, which is really good in medical world. When you think about some of the other treatments, number needed to treat could be 200 or 2,000. So here, if we treat 4 to 5 patients within the first 90 minutes, there's a high likelihood that the person will get better. And as you can see, the later we treat, the more patients we have to treat. And there's a point that comes after which treating is actually more harmful than beneficial. So again, so when the person comes in, that's one of the first questions we ask the EMS, what's the last known normal? Because we want to make sure that we can treat this stroke. This is the main medical therapy that we have at this time. There is another medication that is coming around, which is called tenecteplase, very similar to alteplase, has very similar outcome as well. But there are a lot of patients who either present late after 4.5 hours or who have a really large clot in a blood vessel that is not easy for this medication to dissolve. And in these cases, before 2015, we didn't have any significant treatment. But in 2015, we had a new treatment that came out. We call it mechanical thrombectomy. And it was made possible because we were able to identify the right patients who would benefit from it using advanced imaging techniques. In PROV, we built that imaging modality. It's a special kind of CT scan that helps us see what part of the brain has had a stroke and what part can be salvaged. And if we find the right patient, then these patients can actually benefit from thrombectomy up to 24 hours from last known normal. So it's really important for patients who woke up with the stroke symptoms and don't know when they were not, when the stroke actually happened. It could have happened early after they went to sleep or early in the morning. And so for those patients, it became really one of the only acute treatments that we have available. This is a summary slide. And what it says is that when a patient comes in with a stroke, then everybody gets medical management. So that is something that we provide to all patients. We look at the blood pressure, we look at the medications, the history, and all that stuff. A large percentage of patients, if they present within 4.5 hours symptoms, can benefit from IVL Teplase, with about a third of the patient getting this medication getting better. And then there are select patients who we select based on advanced imaging technology to see if they can benefit from endovascular clot removal. And Dr. Lowe will talk more about this. We were among the first hospital to adopt this protocol within the Providence system. And we transferred our first patient in 2018, immediately after the 2017 data came out from these two trials. And this happened because of lot of help from the foundation. Over the years, we have known that we would need to build this ourselves. And the reason is when we transfer a patient outside the hospital, it takes us about 60 to 90 minutes to get them out of Providence. And then it takes another hour for them to be transferred to, let's say, Swedish hospital in downtown. And then they have to take the patient, learn about the patient and take care of them. And that process sometimes was taking 2 to 3 hours. And within that period, the patient's stroke was extending. So with the donations from foundation, we were able to buy this really complex machine. It's a biplane suite, which allows us to do this procedure in-house. And we were very fortunate to get Dr. Lowe here from Swedish to work here with us and build our program. And we started doing this procedure here at Providence in 2021, January. And we've done several cases, which we'll talk about. Our goal is to eventually become a comprehensive stroke center, which requires us to do a few more things than what we're doing. And we're building all of those things at this time. And we also want to build outpatient neurology clinics for our community so they don't have to go far away to get help for after the stroke. So with that, I'll pass my, I'll end this share and pass it back to Dr. Cook.
Great. Thank you, Dr. Singh. And, I do appreciate your strong work here over the past few years and really laying a really solid foundation on which, we've been able to build a robust program. And recently it added the capability of doing this mechanical thrombectomy that we'll hear from Dr. Lowe about here in just a moment. I think it's, and Dr. Lowe may get into this, and I don't want to steal his thunder, but there are over 1 million people that live north of Seattle. And as Dr. Singh mentioned, the time it takes to get them down to Swedish or other hospitals that have done this before we started doing this is excessive. And so us having this capability of this mechanical thrombectomy, which is really a revolutionary treatment for patients with stroke, is really going to impact and is currently impacting in a very positive way the lives of lots and lots and lots of people who live north of Seattle. So, I don't want to take too much more time other than to thank Dr. Singh and briefly introduce Dr. Lowe. He's our go-to guy for this mechanical thrombectomy work and interventional neuroradiology. You have to kind of take a breath before you say all that because it's a lot of syllables. And we're going to ask him to tell us all about it, starting with explaining exactly what a mechanical thrombectomy is and how this is important in someone who's had a stroke. So, Dr. Lowe, please take it away.
All right, thanks for the intro, Dr. Cook. First off, I'd like to lead off by saying thank you for having me for this webinar. And I want to extend my deepest thanks to everybody as part of the foundation, because the foundation really has made the ability to deliver thrombectomy possible. And that not only creates the ability to provide this service, but it's actually directly affecting the patients, the lives of these patients and patients that live in the community. So it's a huge impact. And as I will show you, it has already shown and borne out in this first quarter to have a large impact. We can start with my slides, and as you cue those up, I also wanted to say that the Dr. Singh mentioned about the number needed to treat. And the number needed to treat, as you saw, if you gave TPA very early on, the number to treat was close to anywhere from 4 to 6. The number needed to treat for a thrombectomy, if you showed up with a large vessel occlusion, or meaning a big clot blocking up one of the major arteries in the head, the number needed to treat was 2. So every 2 people that you treated with a catheter, one of them would have an improved outcome compared to the natural history. So this has been likened to penicillin with regards to medical care and medical history in terms of its impact directly on the lives and livelihoods, because it actually not only affects morbidity, meaning we can decrease the number of people that die from this, although not statistically. We can significantly improve the number of people that become return to a level of independence, and really that's the goal outcome in these people with large strokes. Let's start with that slide. So this is I want to give credit to Covidien Medtronic. I want to keep this unbiased, but this was actually freely available on YouTube, and it was I'll unbias it after it's done playing.
This animation shows how we perform stroke intervention in patients. When a patient is having a big stroke, there's typically a blockage of one of the major blood vessels to the brain. That blockage is often caused by a blood clot that forms somewhere else, like in the heart or in the carotid artery in the neck, and then breaks off and travels up and plugs up one of the main arteries going to the brain. So that part of the brain is at risk of dying because of the lack of oxygen and nutrients from the blockage from the blood flow. In situations like this, we can intervene. We can go in from the femoral artery in the leg with a catheter, as you can see here, place it in the carotid artery in the neck, that's the blue catheter. Through that catheter, we take up a smaller catheter, a microcatheter, and we catheterize the arteries inside the brain, the carotid artery, and into the middle cerebral artery. You can see the clot within the middle cerebral artery, which supplies blood to that half of the brain. So we bring up our microcatheter all the way up into the middle cerebral artery in the brain and cross the blockage. Once we're across the blockage, we bring up a mechanical thrombectomy device, which is kind of a stent on a stick kind of configuration. It's a stent-like device that we unsheath within the clot in the blockage. You can see the stent is opening up and actually restoring blood flow immediately. We then give it about 5 minutes, allowing the radial force of the stent to open up outward and allowing the clot to extrude within the lumen or inside of the stent. After the 5 minutes is over, we inflate a balloon in the carotid artery in the neck, which arrests flow, and then we pull back the stent retriever device with the clot entangled inside it into that balloon catheter. The purpose of inflating the balloon in the carotid artery in the neck is to reverse flow from the brain arteries and into the catheter out of the patient's body. In this way, any particles that break off from the blood clot within the stent retriever will get sucked out of the patient's body. They don't go out distally and cause more strokes.
So the things that I would add to this is we are probably doing about 50% of our strokes through the wrist and not necessarily through the groin. The video was unbiased in that it did not mention any specific products, but there are a couple other devices out there, several people that make stents. We don't necessarily always have to use a balloon in the neck. There are also large catheters that we can take up to the brain to engage the clot and pull the clot from the proximal aspect, just like grabbing it and pulling it down. The technology of this space is actually very exciting. There's a lot of competition for people to make better and better mousetraps, essentially, to get the clot out. And we're really aiming towards the ability to pull the clot out in its entirety in its first pass. That's really our goal. One of the things that Dr. Singh also mentioned in terms of the transition time, if you're at a spoke hospital, meaning a hospital that's already had a transfer arrangement, much as Providence Everett had before we went live in 2021, if you have a spoke hospital where somebody arrives with a large vessel occlusion, in the studies that were done in 2015, the average time from arriving to your spoke hospital to when you actually showed up to the target hospital, the hub hospital, was 90 minutes. Furthermore, they broke down that every 30 minutes that you had in a delay categorically put you in statistically into a higher chance of being one point more on the disability score, which is a 6-point score. So if you can reduce those times by 90 minutes, avoiding the whole transfer time, you have theoretically a better chance of having an outcome where you have zero disability. I had some further slides actually after the. So I'm going to switch gears and show a couple cases. Some people have already seen some of these slides, but this was actually two of our first cases within the first 2 weeks. So this was January 6th. It was a 8 p.m. arrival. The patient had a fairly large, the patient was not that symptomatic, but they recognized that the patient had a stroke, was having a stroke. They did directly go to CT scan. They got the alteplase, the blood busting medicine, in 35 minutes, which is a very fantastic time. And this was actually from the medical chart, was that they had noticed that there was the initial right facial droop that was the BFAST that was positive. And then while in the emergency room, they suddenly became unable to move the left side of their body, and it became very difficult for this patient to actually speak. Began vomiting in the CT scanner. The ED doctor went emergently to the CT scanner, intubated them there. At that point, the NIH stroke scale, which on a scale of 0 to 42 tells you how severe the stroke is. Typically, scores of 10 or more are considered severe strokes. 16 is getting to being very unlikely that they will actually recover to a completely independent. And then the CT angiogram demonstrated the worst type of clot, the worst type of large vessel occlusion, which is a basilar clot. So that's the artery. The cartoon that you saw was the middle cerebral artery, and the majority of strokes occur in the arteries that come from the front of your neck and then split behind your eyes. The back of the brain actually controls all of the more primitive functions of the brain, but it's also the pathway between your brain to the spinal cord. So when you have a stroke anywhere in that basilar artery, the basilar artery has not been studied, because we know that if we leave the clot alone, it has about an 80% chance of having death or disability. So it's the most disabling kind of stroke that we see. Fortunately for this patient, after one pull, they were able to get a complete recanalization. That's what this TICI, that's a thrombolysis in cerebral ischemia. It's a score from 0 to 3, 3 being essentially all the blood flow has been restored. He was extubated the next day, and he did go home about 4 days with some home health. He did need some further care with me down the road, but he was able to go home with an NIH stroke scale of 0. And last I saw him, he was completely independent. Next slide. Here's some images similar to the cartoon that you saw, except the artery appearance is a little bit different. So can people see my mouse? Probably not. So the image on the left is the pre. Yeah, there you go. Thank you. The image on the left is pre, and the image on the right is post. The patient is facing to the screen's right. So the back of the head is to the screen's left. And you can see the artery basically stumps at around the middle of the clock there on the image on the left. And then after we are able to remove the clot, you can see that there is continuity, but this patient's reason for having a stroke was because they did have this underlying narrowing that subsequently I was able to treat. Next slide. And this was his ultimate MRI. This was all the stroke that he had. In this image, the patient is, you imagine the patient's feet are pointing out of the screen. So we're looking up into the head. Anything that's bright white is an area of brain stroke that's irreversible. And this small stroke, this is actually a very tiny stroke compared to the occlusion that the patient had, is likely to be completely recoverable as it was in this patient's case. Next slide. This is a case study to show some of the advanced imaging that Dr. Singh mentioned. So this is what's called a CT perfusion scan. So this is a patient, female patient that came in via EMS. They are now able to report what's called the LA motor score, the LAM score. So a score of 4 or 5 has about a 50 or 60% predictability if somebody's really having a stroke that it's actually from a large vessel occlusion. So we really want to identify those and expedite their imaging because we have to mobilize the IR lab team, the IR doc. We need to prepare a lot of different things in order to get the IR suite up and running. So this patient was in CT very quickly, got their altoplace almost at a record time as well, 32 minutes. This patient was, I believe this was a Vietnamese speaker. So there was some interpreting services that was needed. Her initial NI stroke scale was 16, again, very high. And this is a left M2 occlusion. So the picture that you saw in the cartoon was called an M1 occlusion. It just means the first segment of the MCA, but you can still have that branch artery split into 2 arteries, and you can have a clot in one of those 2 arteries, and you can still have a significant deficit. And that's what this patient had. So this image on the left, there's about 12 images on the left half of that image, and then 12 on the right. Typically, the images on the left will produce a purple color, which this patient does not have, but the purple color represents tissue that is predicted to be dead by the CT scan. The images on the right are tissues that will likely progress to death and stroke if the clot is not removed. So the volume there is significant. You know, anything I'd say over the volume of about 25 is something that I would consider for taking to the lab. Certainly in somebody that has no core, no completed infarct, and has this amount of penumbra or tissue at risk, this is somebody that I would prefer to take to the lab. And so the next slide will show the occlusion. So there's that same, if you imagine that same cartoon that I showed you, that first segment of the artery is open, but it splits into 3 arteries. You only see one of those 3 arteries, and you see the stump of the other 2. And after a pass there, you're able to see that the artery is now open, albeit it's a little irritated. It's what's called vasospasm, but that tends to get better. But you can see the restoration of flow with the image on the right. So just to orient you, this is an injection of the artery on the left side going up into the left side of the head. The patient is facing out of the screen. So where that clot is around the, call that the 6 o'clock, near the center of the clock, that's where the blockage is that you can see is open, is blocked on the left and then subsequently opened on the right. Next slide. So this patient actually did well as well. So here's an MRI with the feet pointing out of the screen. Again, the white demonstrates the area of permanent injury. So though the volume of her complete stroke is actually extremely small, and I would actually predict complete recovery as well. She did have some deficits of some facial weakness and some dysarthria, some slurred speech, but she was able to go home in, I believe, about another 4 days with an extremely low NI stroke scale, an improvement in her NI stroke scale. Next slide. I believe that was the last slide. The things that I wanted to recap, this is data that I was just able to look at just within the first quarter, the difference that the foundation has made in starting this service line up is that in comparing to 2019, again, to a full year's data, the length of stay in patients that had equivalent kinds of strokes went down from an average of 10 to an average of 5. So this is proof of concept that the sooner you deliver the necessary therapy, the shorter the length of stay is going to be. So that's very, very important to us. The other part of this is that in this first quarter, 70% of patients went home or to rehab. And I'll tell you that that's extremely, extremely high. It's higher than even, years and years of experience at Swedish that we have. We have about a 62 to 63%. Compared to the entire Providence system, I don't have access to home and rehab data throughout Providence system, but out of the 6 or 7 comprehensive stroke centers that we have in system, we were statistically higher in discharging to home or rehab. And home or rehab has been well established as a surrogate marker for the outcome measure at 90 days. So in the stroke medical research literature, you want to prove that at 90 days, that's your primary outcome measure. How many people are independent? So if you discharge from your primary hospital after thrombectomy and you go home or you go to an acute rehab, it's very likely that at 90 days, you will be completely independent. So again, I want to circle back to the foundation and kind of applaud everybody's efforts in doing that, because you've been the ones that have been able to deliver this care to your community. That's all I have, and back to you, Dr. Cook.
Okay, well, thank you so much, Dr. Lowe. That was an amazing presentation, some amazing stories. It's hard to kind of get, sometimes it's hard to get your head around what's going on here. So when patients come in with a heart attack and get heart cath, that's sort of like playing 2-dimensional chess. That's chess, and you're just looking at the heart in one plane when you're putting in a heart stent. This is like 3-dimensional chess, where you actually have these catheters going through these very small 1/4 of an inch and smaller arteries in 3 dimensions. And it's a really special skill set that Dr. Lowe and his team bring to this. And again, it's all possible due to the generosity of our community. I think that we've gotten a good start on our campaign for Greater Providence. We've been able to raise, I think, around $28 million, but it's still growing. And this is one of the key areas that we are raising funds for, but there are others. And it goes beyond stroke care and neurosciences. And you can see we're also supporting heart care, trauma services, cancer care, and children's services. And if you'd like to learn more about the campaign, and we'll be talking about this more in subsequent sessions, but we have a website that's full of information. It's at agreaterprovidence.org. That's agreaterprovidence.org. And I want to go back just a minute because I failed to mention after Dr. Lowe's presentation, and the technical tour de force that his team brings is really the whole team of people who make this kind of successful program possible, starting with our emergency medical services, our EMS personnel, who are now attuned to the fact that we have this capability here in Everett, and they are bringing people directly to us and are calling in ahead of time with really key information that shaves seconds or minutes off the time that we have to get these patients treated. And as Dr. Singh is fond of saying, time is brain. So every minute that we can shave off our time to get this treatment to the patient is time that is less time that their brain is losing blood flow, and the better likelihood they'll have for a good outcome. And when they get to the emergency department personnel are also spring into action incredibly quickly. We have protocols, which mean that this activity is pretty hardwired into our systems. We take them to imaging. And again, the imaging team is amazing. They know exactly what to do. We don't have to reinvent the wheel every time again, saving, time, saving minutes every step of the way. And then when the patient goes up to the lab where this three-dimensional activity takes place, the team and Dr. Lowe have really orchestrated, a really nice, efficient, professional, no wasted motion sort of technique or process. And again, my hat's off to the whole team here, and it really takes a village to to be successful here. So I want to make sure I acknowledge everybody. So it's been great hearing about our innovations in stroke care from these two extraordinary doctors, and really appreciate their time tonight. And we have some time for questions, and there are a couple in the chat box here that I will ask right now. So the first is, how many stroke patients are airlifted to Providence, and how does that affect outcomes?
Oh, I don't have the number of how many are airlifted, but we do take care of about 700. I think we discharged about 740 patients last year, which is probably very close to how many Swedish hospital downtown, which is much busier hospital, took care of. We are one of the few hospitals that have our own helipad, so we can have actually patients land directly on the hospital, whereas Swedish hospital downtown, does not have that. So they actually have to have patients land at Harborview and then get transferred there, which wastes time. So we are actually in a very fortunate position to be able to accept patients from most of the northern territories, which includes all the islands, includes 5-6 counties all the way from here to the Canadian border. I wanted to also elaborate on what Dr. Cook is saying. We actually have world-class cardiology program. Many of these patients need cardiological examinations to figure out the source of stroke. We have world-class vascular surgery program. Vascular surgeons perform a kind of surgery that has shown to prevent the risk of further strokes in the future. It's called carotid endarterectomy, and we do really well. And we have actually kept up to date with the new innovations in that area. We have strong collaboration with EMS. We have something we are very proud of called Stroke Support Group, that patients who are discharged from the hospital can follow up and have a peer group to talk about their recovery. So it's really a large set of people who take care of these patients the moment they step into our hospital.
Great. Thanks, Dr. Singh. Dr. Lowe, anything to add to that?
No, I think that Dr. Singh has kind of revealed one of our goals over the next couple of years, which is actually to be receiving airlift patients. And I think that Everett's location will allow us to start actually providing care to places that previously probably had to get fixed wing to get anywhere. So potentially Bellingham and all the areas, northern Washington near the border, will eventually have access. I think that Swedish has had relationships with a lot of hospitals that fly patients to us, but I personally have actually clocked that the fact that we actually land at Harborview, transfer to an ambulance, drive 10 blocks, unload the ambulance to get into the emergency room adds about 25 minutes. So based on the argument that every 30 minutes creates one level of disability down that score, it makes much more sense if the flight time is only 1 or 2 minutes difference from going to Everett versus Harborview. It makes a whole lot more sense for those patients from Port Angeles, from Olympic Medical Center, Jefferson Hospital, Island, Anacortes, Whidbey, all of those places that typically fly to us to eventually come to Everett and benefit from again your generosity.
Right.
Great, thank you. Here's another question. if someone has persistent pain in the left temple over a few week period, could this be a potential stroke indicator? And a little note is this is someone who does not have a history of migraines.
Right. And again, I want to put the caveat that Dr. Cook said earlier, which is we are not able to give medical advice. But there is a kind of vasculopathy we call giant cell arteritis, or temporal arteritis. It's a syndrome where people present with persistent temple pain, and then can progress to have usually vision loss. So they'll start not being able to see in one eye. And that's a medical emergency. So if you have that issue, then you need to be seen in a hospital and be evaluated for that particular syndrome. However, I just want to say that headache is a very common thing, and there are lots of other possibilities other than stroke or vasculopathy that can cause temporal headaches. And too many actually diseases that can cause it that I think you should, if someone is having it, that they should talk to a provider and start with a primary doctor, and then keep pursuing until you have an answer.
Great, thank you.
A
Here's
question-
one for Dr. Oh, excuse
that
me,
question-
sorry.
Yeah, no, that question actually brings up a good point, which is that BFAST is really designed to capture the patients that have clot-related stroke. There's a small percentage of people that actually have a ruptured aneurysm, and that's still technically considered a stroke. Bleeding in the brain is also technically considered a stroke. And those two latter things that I mentioned can sometimes present with headache and not neurologic symptoms. So they may not have the BFAST symptoms, but it's not quite like the person's question about temporal headache for a week. These are headaches that somebody doesn't have headaches, and they go from having no headache to 100-mile-per-hour headache in minutes or even seconds. It's not one of these, yeah, I'm having a really, really bad headache and it took me, 12 hours to get there. This is, the sudden onset of debilitating headache is a 911 call, just like stroke and BFAST.
Great, thanks for clearing that up. That's super important. Here's one for Dr. Lowe. What is the future of stroke care, and can it get even better? And I will add on to that, what is the future of interventional neurosciences at Prov Everett beyond stroke?
Oh, you guys are this is like a staged question. I love it.
Yeah,
This is really what gets me excited. And
Yeah.
I'll tell you that my vision is that we will be able to provide this to spoke sites remotely. And you may not believe it now, but we have what's called a Corindus robot. There are a couple companies, again, I want to be unbiased, but there are a couple companies that make robots. And these robots are not what the robots that you think of in terms of hands and things like that. It's a very simple system that actually converts a manual dial and knob. And I can put it in the chat. There's a website that we recently gave a cerebral vascular symposium, and we did a live feed of a live patient. But essentially, it has a wired and eventually wireless control of knobs that controls the coaxial movement and rotation of catheters. So all I'm doing after I get access, let's say into the wrist, once a tube is inserted, all I have control of is the catheter and the wire outside the body. I don't have any ability to move anything on the inside, but by moving it on the outside, it translates through the technology of catheter and wires all the way up into the brain. So all I need to do is be able to see it on a screen and control the way that the robot has the catheter and the wire laid into it. It has these gears and mechanisms that twists the catheter, advances the catheter to a millimeter point of accuracy. The technology is not quite there yet in terms of thrombectomy, but it goes to logic would show that everything that we do is what's called coaxial, something within something else within something else, and everything is linear and tubular. So right now the system has just enough gears to move the catheter and the wire, but if you can imagine, we add on another third and a fourth, and now we have 4 catheters and 4 wires that go all within each other. You may have a longer robot arm, but that's essentially what we can do now remotely. And I think that that's going to happen probably within the next 2 to 5 years. And really, I want Everett and Swedish to be the forefront within the whole Providence armamentarium to show that we can actually deliver this, because it also makes more sense. And instead of flying that patient from Bellingham to Everett, if you can do the work needed to establish all the necessary ground rules and ground equipment that you need, you can actually have the doc at Everett dialing into Bellingham, having somebody get access for you, and then delivering the thrombectomy right there. And then you cut that 90 minutes of transport time out, just like we did with the Everett patients that were coming down to Swedish. That's my vision. It's not FDA approved yet, so I'll use that as a disclaimer.
That's so cool. Give us just a little taste of what else in the neurointerventional world, maybe coming down the pike for Everett beyond thrombectomy.
Yes, so thrombectomy actually only recently, probably within the last 10 years, six to 10 years, has become more of a work volume for neurointerventionists. Prior to this, we really were spending the majority of our time coiling aneurysms or treating aneurysms. And that space is as exciting as the thrombectomy space, because there's so much competition for companies to provide a better mousetrap. So the aneurysms, as I mentioned, in terms of the patient that had the question about the headaches, the same risk factors that produce a stroke, which are high blood pressure, cholesterol, smoking. In addition to those, gender and genetics adds to weakness in the artery walls. So as opposed to the clot that blocks up the artery wall, what you can have is over time, somebody has repeated injury to a branch point of an artery. That branch point has this constant injury at where it branches, and it creates enough injury and it cannot repair itself in time, and a blister forms. And that blister is called an aneurysm. Sometimes those aneurysms can be acquired and never rupture, but we have a way of trying to predict and identify those patients that have aneurysms that are large enough or of an anatomy that may rupture. So we either treat the aneurysm after they've ruptured, which unfortunately the outcomes of that are still fairly poor. About 50% survive. So once the cat is out of the bag and the aneurysm has ruptured, the outcomes become limited. But we will have the ability at Everett to start treating these aneurysms electively, so to prevent somebody from having the risk of rupture over the rest of their lifetime. But the technologies that we have now are just gaining exponentially. Traditionally we had coils, then we had the ability, and these coils are small little metal strands that are very, very soft like hair. We pack them into the aneurysm so there's no more space for blood to go into the aneurysm, and then eventually the aneurysm fills with clot, and then that clot turns into scar tissue, and then that scar tissue slowly moves back to the interface where the artery wall is, and then the artery wall remodels. The coiling has been added to have the adjunct of a stent, and those stents have gotten better, second and third generation stents, that they produce some degree of flow diversion, so they're actually preventing blood flow from jetting even into the aneurysm anymore. So with coils and these second, third generation stents, you're having a higher and higher durability, where you check them at 10 years and they still remain occluded. And we have a couple devices called flow diverters. So as opposed to even needing to put coils into the aneurysm, you can put a tube that's a mesh of metal that prevents blood flow from getting into the aneurysm. It creates enough resistance that the viscosity of blood tends to want to keep the blood inside the middle of the tube as opposed to escaping into the aneurysm. The aneurysm, just like with the coils, causes clot, causes scar tissue, and then that scar tissue slowly comes back until the body heals along the inside of that flow diverter. So we are at an exciting time with neurointerventional that we will slowly be replacing most of the open surgical treatments for these type of lesions.
That is so cool and exciting. And, this is all, again, made possible, with the generosity of our community, and it's for the benefit of our community. And I want to thank Dr. Singh and Dr. Lowe for taking their time for us this evening, and thank all of you who joined us tonight. We've recorded the session, and we'll send you an email with a link to watch, and you feel free to share that recording. with anyone who may be interested. I also want to give a quick plug for our next topic from 4:30 to 5:30. We'll be talking about behavioral health, both in adults and in children, which is a very timely and important topic, especially with the impact that COVID-19 has had on mental health. Laura Knapp, who is our Director of Behavioral Health here at Prov Everett, will be one of our guests, and I expect this will be a very popular session. Please tell your friends and family members who may be interested. And again, that'll be June 17th. I think it's a Thursday from 4:30 to 5:30 p.m. And look for an email that'll give you more details and some registration information. Again, thanks for being with us this evening. We hope you got to know us a little bit better and learn something about stroke and how the team at your local hospital here at Prov Everett is here to help. We appreciate your time and partnership. Have a great evening. Thanks.